My name is Peter Forsberg. I'm an assistant professor at the University of Colorado. I'm a plasma cell disorders specialist, so I'm excited to learn about lymphoid malignancies from our wonderful panel of experts today. We really have a world-class group of providers here to share information on a number of interesting cases. So I'll ask them to introduce themselves. Dr. Pagel.
I'm John Pagel. I am not a plasma cell specialist. I actually focus on lymphoid malignancies, really exclusively do research and, of course, patient care in lymphomas and CLL, and I'm at the Swedish Cancer Institute in Seattle, Washington.
Hi, I'm Michael Thurman. Thank you very much for inviting me to participate in this tumor board. I'm on the faculty at the University of Chicago, and I specialize in lymphoid and myeloid malignancies.
Pleasure to be here again. Thank you. I'm David Schuster, and I'm a radiologist. I'm Division Director of Nuclear Medicine at Emory University in Atlanta.
So this is a 67-year-old male diagnosed with mantle cell lymphoma in 2012, completed chemotherapy followed by autologous transplant, and now with a biopsy-proven recurrence. So we'll discuss recommendations for treatment and what factors may shape that. So the patient presented in the setting of weight loss, 20 to 30 pounds over 2 months, abdominal pain and fatigue, ECOG performance status was 1. History of GERD and a remote history of a GI bleed, essentially we'll consider non-contributory social or family history. So in 2012, patient was diagnosed in the setting of progressive fatigue, diarrhea, anemia, underwent a colonoscopy that showed congestive mucosa with multiple nodular masses, and the biopsy demonstrated mantle cell lymphoma, which was CD5, cyclin D1, and SOX11 positive, CD23 negative. Ki-67 was 30%. Blood counts at that time showed a hemoglobin of 8, platelets of 75, an absolute lymphocyte count of 6,000. CT scans showed splenomegaly and diffuse adenopathy. Peripheral blood flow demonstrated a CD5 positive, CD23 negative clonal B cell population with the presence of a translocation between 11 and 14 on FISH. Patient was treated at that time with R-hyper-CVAD, so this is in 2012, R-hyper-CVAD, followed by autologous stem cell transplant with a complete response. So now 9 years later, patient develops anemia with a hemoglobin of 9.5, thrombocytopenia, platelets of 100, and increased absolute lymphocyte count to 9,000. CT scan with diffuse adenopathy and conglomerate mesenteric mass, and a biopsy of this mass demonstrating, again, mantle cell lymphoma, CD5 and cyclin D1 positive, CD23 negative, Ki-67 of 25%, and cytogenetics demonstrating a complex karyotype with 17p deletion. So Dr. Schuster, your thoughts on the imaging?
Yeah, so here we can see the bulky mesenteric mass, upper right retroperitoneal mass, and then there's splenomegaly as well, which may indicate involvement. So it looks like this is where the patient's disease is according to the report.
So to move into treatment considerations in this patient, Dr. Thurman, thoughts on this patient now relapsing 9 years after their initial treatment with initial therapy, including autologous stem cell intensive therapy followed by autologous stem cell transplant.
Well, so this is an interesting case because it's such a late relapse. Everything was, done appropriately, aggressive treatment up front, followed by stem cell transplant, and then to relapse 9 years later. It's obviously, on the later end of the spectrum, although not a surprise for mantle cell lymphoma. At the recurrence, there's a deletion 17p indicating that the disease is going to be refractory to chemotherapy potentially. And again, this is a situation that you have to decide how aggressive the patient wants to be. I think the good news is that CAR T-cell therapy is available for relapsed mantle cell lymphoma and is approved. So this is someone who you would like to get to CAR T-cell therapy. Again, the question is how much treatment you give before CAR T-cell therapy to try to get the disease under control. For Patients who are not good candidates for CAR T cell therapy, there are a number of ways to go. BTK inhibitors have excellent response rates in relapsed mantle cell lymphoma. Venetoclax, combinations of BTK inhibitors with venetoclax and CD20 antibodies have been reported to have very high response rates. PI3 kinase inhibitors have also had excellent response rates. So depending on how you wanted to go with this patient, you could imagine several possibilities in terms of oral chemotherapy or oral targeted agents. And then if the patient's performance status were acceptable, then CAR T cell therapy would be an option as well.
Dr. Thurman, if you were to try to target, CAR T cell therapy, and in terms of getting the patient there, would the treatment considerations be similar in terms of a bridge or reduce, sort of cytoreducing, sort of interim therapy?
Well, yes. I mean, I think that you could imagine trying to give some salvage chemotherapy so the patient doesn't progress while you're waiting for CAR T cells to be produced. Again, the deletion 17p patients don't respond that well to chemotherapy, but it would be definitely, worth considering in this case.
Your thoughts, Dr. Pagel?
Yeah, I think that Michael really summarized this very, very well. This is a tough case. This had a nice long remission, but it doesn't matter now with a complex karyotype and a 17p deletion. This is aggressive disease. And, with mantle cell, that's not uncommon. When they relapse, it's biologically different disease. And this patient needs to get to CAR T for sure. For me, I wouldn't drag my feet too long on this one. These mantle cell patients with 17p deletions can just explode so quickly that you may never get them there. So I'm going to maybe treat some of these patients with a BTK inhibitor while I'm teeing up the CAR T cells. This patient, if I remember from Dr. Schuster's images, that there was a fair amount of disease with a pretty big spleen. I'm going to probably give this patient, yeah, there we go. You can see that spleen, they're quite fairly big. I'm going to probably give this patient a cycle or two of chemotherapy to try and just get things under control quickly. I totally agree with Dr. Thurman. Those patients don't do great with chemo for very long. The whole goal is just to try and get as quickly as we can to CAR T cell therapy. And there is, of course, commercially approved CAR T cell therapy for mantle cell lymphoma. Very important for people to remember that. You don't want to miss the opportunity to get this patient to a CAR T if you can.
So to summarize in this, somewhat atypical, but not entirely unexpected circumstance of a patient relapsing, several years after initial intensive therapy with R-hyper-CBAT and stem cell transplant, now with aggressive biological features, including a complex karyotype and 17p deletion, strong preference to try to get the patient towards CAR T cell therapy, potentially using chemotherapy or a targeted therapy to bridge. Given the potential for aggressive disease behavior. Alternatives outside of CAR would include BTK inhibitors, venetoclax, combination therapies with these targeted approaches or CD20s, but favoring to really strong consideration of CAR T as a good approach for this patient.